Hi, this presentation is the basics of intellectual and developmental disabilities and dementia for direct care professionals. I'd like to thank and acknowledge the Department of Health and Human Services, the Administration for Community Living, for their support of the work that's being presented here. Also want to recognize the National Alzheimer's and Dementia Resource Center, which supports my work as a consultant on intellectual and developmental disabilities and dementia, really working with community organizations and across the country, seeking to better include people with intellectual and developmental disabilities in the efforts we're all making to better address dementia. So this video is of a presentation that I prepared for Memory Lane, the grantee for the Administration for Community Living and for Summit County, as part of grants that they received from the Administration for Community Living. It can be used in a variety of ways to support training for direct care workers, certainly across Ohio, but also across the country. It will be available online. It's also something that's available to trainers to utilize when they are doing in-person trainings or local trainings of direct care workers, supporting people with intellectual and developmental disabilities and dementia. You're going to see as we move along that there are places where I stop, because I also recognize that in the delivery of these trainings, sometimes it's helpful to be able to do part of the training at any one time. And so I encourage people to use this as creatively as they feel necessary and able, because my goal certainly is that a large number of direct care workers get the opportunity to complete this training. And hopefully that will mean that we can influence the care that is being provided, while also recognizing the criticalness of the people who are providing that care. So we have a number of learning objectives. We want to gain a basic understanding of dementia. We're going to focus in on communication strategies and skills that can be used in day-to-day care of people with dementia. We're going to think about person-centered skills and learn how they might be applied to the care of people with dementia. And, but I think perhaps most of all, we're going to be thinking about and learning about what can be changed or modified in order to provide the best care possible for persons with intellectual and developmental disabilities and dementia. I always think about, and starting with any training around dementia with people with intellectual and developmental disabilities, that let's not just talk about the challenges and the dementia. Let's also talk about what we've succeeded in doing. It's not that long ago that very few people with an intellectual and a developmental disability live to old age. It's a real success story. And there are many people with an intellectual or developmental disability who are leading quite independent lives or enjoying their aging years. But like all of us, as we get older, there's also the risk for chronic health conditions to develop. And among those conditions is dementia. We actually don't know a lot about the aging of people with intellectual and developmental disabilities, and perhaps have not done as much as we could have in the past around promoting lifelong health. So I think also that as we think about the things that we're going to be talking about today, also to be thinking about for younger people with intellectual and developmental disabilities are the things that we can do that can promote better health, that can help people to maintain their independence. We want to be focused upon postponing additional disability for people with intellectual and developmental disabilities. We need to be thinking about how do we need to reorient our services, and how do we still achieve and emphasize a mainstreaming agenda, and to the extent possible, including people in integrated ways into the services for people with dementia. So I'm going to stop sharing these slides, and I'm going to share now a video It's a short video, but I think it's an important video because it helps to illustrate what happens for people with dementia.
Alzheimer's is a slow, fatal disease of the brain affecting 1 in 10 people over the age of 65. No one is immune. The disease comes on gradually as 2 abnormal protein fragments called plaques and tangles accumulate in the brain and kill brain cells. They start here in the hippocampus, the part of the brain where memories are first formed. Over many years' time, the plaques and tangles slowly destroy the hippocampus, and it becomes harder and harder to form new memories. Simple recollections from a few hours or days ago that the rest of us might take for granted are just not there. After that, more plaques and tangles spread into different regions of the brain, killing cells and compromising function wherever they go. This spreading around is what causes the different stages of Alzheimer's. From the hippocampus, the disease spreads here to the region of the brain where language is processed. When that happens, it gets tougher and tougher to find the right word. Next, the disease creeps toward the front of the brain, where logical thought takes place. Very gradually, a person begins to lose the ability to solve problems, grasp concepts, and make plans. Next, the plaques and tangles invade the part of the brain where emotions are regulated. When this happens, the patient gradually loses control over moods and feelings. After that, the disease moves to where the brain makes sense of things it sees, hears, and smells. In this stage, Alzheimer's wreaks havoc on a person's senses and can spark hallucinations. Eventually, the plaques and tangles erase a person's oldest and most precious memories, which are stored here in the back of the brain. Near the end, the disease compromises a person's balance and coordination. And in the very last stage, it destroys the part of the brain that regulates breathing and the heart. The progression from mild forgetting to death is slow and steady and takes place over an average of 8 to 10 years. It is relentless and, for now, incurable. Helping your family, friends, and neighbors to better understand Alzheimer's will reduce stigma, improve care, and even help the fight for a cure.
So I'm going to return to the slides that we were using. So short video, it presents the progressive decline that occurs with Alzheimer's disease and other dementias. And I'm going to talk about what I mean by Alzheimer's in a moment. And it talks about the relentlessness of this disease and the difficulties of this disease. And so we're going to emphasize some of the points that are made in this video, and I'm going to talk about some of the things that we can do despite what's occurring in the disease. So dementia is really an umbrella term. The majority of cases are Alzheimer's disease, and that's particularly true for people with intellectual and developmental disabilities. And it is it's a disease in which the decline that occurs, as you saw in the video, is long. It takes a while. It goes through certain stages. It attacks certain parts of the brain in a particular order. When you hear about or look here on the slide at the other types of dementia that can occur, vascular, Lewy bodies, Parkinson's, frontal temporal dementia, these begin in different parts of the brain. Their progress is a little different, but ultimately, all types of dementia will get to the same end point, and to a stage of severe dementia where the person loses their memories, loses their ability to manage their lives, even to some extent loses the ability to manage their own body. Sometimes Alzheimer's disease co-occurs with other types of dementia, for example, vascular dementia or vascular disease. And so that means that even though someone may have Alzheimer's disease, their passage through the various stages may look a little different because there are other types of dementia that may be of influence. But essentially, it's about a long-term decline. So again, sort of just want to emphasize some of the things that were talked about in the video. That because of where the damage starts to occur in the brain often means that there are things that we can predict in terms of what the changes are going to be for the person. So when it happens in the frontal lobe, in the front part of the brain, someone who was able to dress themselves before no longer can. They don't know what they're doing anymore when they go to the bathroom. They just walk away from activities. They can't sit down. They don't sit down. They dash into the road. And these are particularly if these were things that they had greater control of before. And I think that that's the word to think about, is that they don't have control and they don't understand things in the way that they once did. And it's also a major struggle for the person themselves. And so that's why we see things like people calling you a derogatory name, touching people without their consent, refusing to take medication. Within our brains, we're trying to keep some kind of control, but our efforts to keep control sometimes result in these outbursts. And also, we don't have the same level of control over the way in which we behave. When we look at other areas of the brain, like the parietal lobe, so all of a sudden I don't know where things are. Even though you tell me 6 times, I still don't know what you just told me. I startle when you approach me. I miss the chair when I try to sit down. I shuffle my feet. I reach out to pick up something, but I knock it over. I get into the shower, something I've done all my life, and I scream when you try to give me a shower. I tell others that you've hurt me when all you're doing is providing care. This really speaks to that what's happening for me is, again, that this idea that I don't have full control over my body anymore, and I don't understand the things that are going on around me. I don't have the ability to interpret my environment, to understand what's going on. When it reaches that area, as they talked about in the video, where I stop having control over my emotions, so I may be crying or upset, but I can't tell you why. My language is starting to break down. I use the wrong word to describe things. I start to have difficulty with concepts like he and she. Again, sort of not knowing what to do, even though sort of there are signals to me that, for example, if my clothes are soiled, that I actually don't really understand what that means. The other thing that starts to happen is that I start taking longer and longer to respond, even though you think you asked me a really simple question. Perhaps the answer is yes or no, and I can't get the words out. I'm having more and more difficulty understanding the world around me. The example here is that I'm convinced that the lamppost outside my window is a man watching my every move. And I become accusatory because I don't understand why I can't manage in the world in which I find myself. And when it then comes to that base part of the brain, that this is when sort of I start falling, I tremble or I shake, I struggle, I can't walk, I have trouble eating, and I may end up bedbound, and in sitting in a chair, I may tip over or slide out of the chair. I can't control my body in those places. So those are the kinds of things that happen for all of us. But let's talk a little bit about Alzheimer's disease and people with Down syndrome. So when we think about Down syndrome, which is a type of intellectual and developmental disability, we know that there's a gene that's associated with chromosome 21. But the interesting thing is that there's also a gene located on chromosome 21 that is linked to Alzheimer's disease. So people with Down syndrome, like part of having Down syndrome is that you have an extra copy of this chromosome. Well, if you have two copies of this chromosome and the gene exists there, then clearly you're at higher risk. And the data actually really supports that. For people with Down syndrome, onset of Alzheimer's disease tends to be at a younger age, and you're more likely to start showing the signs and symptoms. So in the bar chart here, if you look at the red bars, which are people with Down syndrome, there are some people who start to show symptoms of dementia from about age 35 on. More likely to be sort of within that 50 to 59 age group. And by age 60, about 75% of people with Down syndrome are showing signs of dementia. Whereas if you look at the blue bars in the bar chart, well, that's about people with intellectual and developmental disabilities where it's not Down syndrome. And you see that about 15% from age 65 on, 23% from 75 on, and it's at 85 and older that it's about 70%. This looks more like the general population. These figures are a little higher for people with intellectual and developmental disabilities that are not due to Down syndrome, but it's much closer to the general population. But clearly, people with Down syndrome have earlier onset, and more people as they get older will show the signs and symptoms. So some people ask me about what about people with autism, and I have to say that not as much is known about dementia in this population. Some of that really speaks to that there are probably certainly middle-aged and older adults who perhaps have autism, but perhaps were never diagnosed with it because that wasn't a diagnosis that we were looking for when they were young. We are clearly seeing growing rates of autism, and so we're paying more attention to this. So there are some studies that are looking at adults with autism and trying to understand what happens for them in terms of dementia. We are concerned that some issues that may be about dementia are being confused with behavioral issues. We're also concerned that we really haven't done a lot of work around what are the appropriate assessment instruments to be able to measure dementia in people with autism. It's always been an issue for people with intellectual and developmental disabilities in general, that the instruments that we use, the tests that we use for the general population don't really work. But we've not tested even the instruments that we've developed for people with other intellectual and developmental disabilities with people with autism. So there's work to be done there. But there's at least some indications that for this group too, the group with autism, that onset is earlier. And so we really need to be doing much more work to understand this. I'm going to turn now to some of the things that happen when we have Alzheimer's disease or another dementia. And clearly, one of the things that we always talk about are what happens to people's memories. And often what I describe is that people's earliest memories go first, and their long-term memories last much longer. But when we think about memory, memory is actually quite a complex thing. How do you know that it's dinner time? Certainly somebody could call you, but the likelihood is that if somebody's been cooking something in the kitchen, you get that aroma of really good food that you really want, and sort of you start to feel hungry, and you think, okay, I'm heading to the kitchen or I'm heading to the dining room because I want to eat. And those kinds of associations between smells, between things that we see, things that we touch, then form what we call our sensory memory. And sensory memory can last quite a while. There are things that we use a lot, and those are and things that are more present in the present, and they tend to be in our primary memory. And it's kind of like when you see somebody you haven't seen for a long time, and you know them, and you're just trying to think, what's their name and what do I associate them with? And then all of a sudden their name pops into your head. Well, that's more of a secondary memory. It's a memory that we don't use as often. We don't think. I actually think it's much more that we don't think about it as often rather than we don't use it, because in there are things that happen episodically. It's Thanksgiving, it's July 4th. There are things that you expect to see happen, and you know what's going to happen on Thanksgiving or July 4th. There's what we call semantic memory that helps us to understand meaning. What's the meaning of things that we encounter? And then there's the procedural memory. When we talk about sort of when you learn to ride a bike, if you've ever learned to ride a bike, that you'll always remember how to ride a bike. Well, how does that happen? Well, because there's a procedure to successfully navigating the roadway using a bicycle. And if you've learned that procedure and it's become imprinted within your memory, you'll remember how to do it. And so what I think about then is that when I'm working with someone who now has a dementia, that probably their primary memory is they're having a lot of difficulties with that. But what about those secondary memories? What about that sensory memory? That perhaps there are things that we can do that people can still enjoy their lives. And that I don't just focus upon, well, he doesn't remember what happened this morning. Perhaps that's not the most important thing to remember. And certainly I'll enjoy a lot more doing things that I still remember than being reminded that I can't remember what happened this morning. And then I think about issues of communication. That one of the things that we see as people have dementia is they have more and more difficulty communicating or understanding your communications. So communication's a really interesting thing when you give it some thought. Like, how is it that we know how to talk to one another? We don't really think about that, but we developed a particular way. There are some rules, what we call pragmatics. You say something, I listen, I then respond to what you just said, and then you listen. Okay, sure. We can think about people and perhaps even sometimes ourselves where we don't follow those rules exactly, where people talk over one another or they don't really listen and things like that. But by and large, that's how we manage communication. So we communicate with words. So how do we know the meaning of those words? We've stored up this sense of meaning of words, and we call that semantics. And then we organize those words in a way in which we can convey an idea or an instruction to someone else. And that's what we call syntax. It's both about the ability to formulate a sentence, and it's about the ability to comprehend the sentence, to understand what the person's saying. When someone says a sentence to you, you know what you're looking for in the words to be able to make sense of it. And then there's just the very basic word production. So again, when I think about Alzheimer's disease and what happens for people with dementia, these things start to break down, that people start to have more difficulty with the pragmatics. They don't remember the meaning of the word. They have great difficulty with syntax, with sentences. And in the later stages of the disease, they're going to have great difficulty even producing words. So if pragmatics tend to go first, what can we do to make sure that pragmatics don't represent a problem in continuing to communicate? So we think about this, and as we think about Alzheimer's disease in particular, but dementia in general, we tend to think in terms of early, mid, and late stage disease. So in the early stage, when the pragmatics are starting to break down, where people are having difficulty, some beginning difficulties with understanding words or even managing sentences, there are things that we can do. So probably the most important thing is to start to simplify language. You know, it's always interesting to just step back a little bit and think about how you try to tell people a story, or how you try to give people instructions, and how simple is it to understand what you're saying. You're clear about what the meaning is, but what's the meaning for other people? And could I say it in a simpler way? Um, I know people that really like to tell long stories, and not everybody has the attention span to hear a long story. And when you have dementia, you definitely don't have an attention span. Perhaps you had a longer attention span in the past. We need to be checking in on what the person's attention span is now. If people don't understand, well, then let's think about different words, other information. There are going to be difficulties in the communication. There's going to be pauses. And there's a great temptation, because you feel badly for the person, that you're going to want to fill in those spaces, not to make the person uncomfortable, is the way we think about it. But in actual fact, we are making things more difficult for the person when we do that. So we should try to avoid talking for the person or filling in the words. Let's give them the space to be able to participate. Let's also give people the time to process what we're saying. They're not going to pick it up as fast as they did before. And we need to be more organized in the way that we present things to people when they have dementia. You know, tell them what we're going to talk about, summarize what the key issues are, then give them the details. We often, in conversations, start out much more with the details, and what this is all about, we figure out as a conversation goes along. When I have dementia, I'm not good at figuring out as I go along what the conversation is. And then always, summarize and rephrase to help me to understand, to help me grasp what it is that you're trying to say to me. I've talked before about that the most recent memories go first, longer memories last a long time. So how about let's spend more time with the things that I do remember rather than what happened this morning. So let's reminisce. Let's talk about those memories I still have. I'm going to struggle with some of this. And again, sometimes our response is that we don't want the person to get upset. Let me express my feelings, because that in many ways can just make me feel more uncomfortable, more of a struggle. What you can do is express support and express to me how much you care about me and want to support me. We give each other a lot of messages, and we're clear that this is the really important message. But when someone has dementia, let's tell them what the really important messages are and what we're saying. And let's think about other ways in which we can help to jog people's memories. Will a picture work? Will, playing a favorite piece of music? Will having people go for a walk in a place they've always enjoyed walking in? These things jog our memories. They make our life more comfortable, but they also make it easier for us to communicate because there's a familiarity with them. And when we want to give people instructions or we want to give people information and we know that they're a little bit overwhelmed because of their dementia, sometimes what we do is that we think that we're helping people by let me tell you right in the moment when you need it. But think about that issue again of sort of, I need to process, and it's going to take me longer to process. So give me the information before it's needed, so that I have time to think it through and really understand what it is that you're saying. So I like this rule, the 7 and 7 rule, that when we're talking with someone with dementia, try to use a statement, first of all, and not ask questions, but try to use a statement that has 7 words or less. It's time for lunch. Then allow the person 7 or more seconds to respond. Repeat your statement if the person doesn't seem to be getting it, once if necessary, but just once. Simplify your statement. Maybe 7 words are too much. So sort of think about, and what really is important to me in that is that idea that those of us who are not showing signs of dementia are taking a greater responsibility to make sure the communication happens. So when people move into the moderate stage, well, what we're going to see is that people are going to have more and more difficulty understanding what's going on. It's a funny sort of thing to think about, but think about how often you're approaching somebody and you start talking before they can actually see you. And usually what that means is that the person turns around, they pay attention, they recognize your voice. In dementia, all I know is there's a voice. I don't know to turn around. I may not recognize the voice. It's actually a little disturbing. So try to only speak when visible. Use the person's name and your name as you talk with them. Avoid statements like, do you know who I am? That just emphasizes to people that there's a problem. As well as words, use overemphasis, gestures, facial expressions, pointing to familiar objects to help the person get anchored to really understand what it is that you're trying to say. Make sure you've been understood. And again, wait for the person to respond. And if they don't respond, just repeat the once. Again, sort of try a different, simpler way rather than repeating things over and over. Ideas like he and she they're actually a pretty complicated concept. And that level of syntax, that level of semantics, of meaning, that those words are important for in our sentences, don't work anymore for people with dementia in the middle stage. So don't use, even though it may feel a little awkward to keep using the person you're referring to when you say he or she, use their names. Help the person to have a predictable routine, engage them in familiar activities. This is not a time to be learning new things. You're going to really struggle. But let's do things that I remember doing. And then give me clues. Give me as many clues as possible. Put signs on doors. What's behind that door? Use pictures, not just words, because perhaps I can't manage words. Perhaps I never could manage words. So use pictures. That cupboard in the kitchen where the cups always are. Put a picture of a cup up there, and I'll find the cups much more easily. It's going to be difficult, and so we need not to take it personally when people don't understand us, or perhaps they understand someone else and they don't understand us. That's always a little tough. Listen and repeat the things that the person says. If you don't quite understand them, it's okay to ask the person to repeat. I encourage and praise people when they make the effort to communicate. Use all available cues and what they try to say, what they're pointing at. Look for nonverbal expressions there too. Look for the things that people are pointing at to try to figure out what they're saying. And here's another thing just to think about. When you think about having conversations with people, how often do we change topics in the middle of a conversation? And again, like sort of sometimes I'm surprised by the change in topic, but I catch up. I realize, oh, you're not talking about that now, you're talking about this. In dementia, I won't know, you're not talking about that now, you're talking about this. I'm just going to be confused. So again, sort of we need to be monitoring ourselves in the way in which we conduct our conversations. And again, sort of long and complex sentences are tough to understand. So try to avoid those, try to break them up. Remember that 7 and 7 rule. So in the severe stage, things are really starting to break down in terms of my ability to communicate. Some of the things that we've been doing already in terms of speaking only when visible, using people's names, giving your own name, but let's smile. Let's keep our voice low, affectionate, and subdued. Again, use overemphasis, gestures, facial expressions. we need to speak more slowly and more clearly. But I want to be clear that this is not about talking to someone as if they're a child. It's about being clear in the way that we pronounce words. It's about slowing down how we talk, so that the person has a greater chance to hear those words. The person may not respond, but I always think that we should be assuming that the person is hearing. There's something about a voice, there's something about a low and affectionate voice and that tone that can be very reassuring to the person. So let's continue to talk. Often we're in a room with other people. We shouldn't be having conversations with other people about the person with dementia as if they're not there. When we're talking to someone, just keep talking, even if there's no response. Use touch. When someone makes the attempt to speak, the likelihood is now, again, if you think back to what I said about communication, their ability to produce words will have broken down, respond to any kind of noise, sound, words that they say, even if it seems pretty meaningless to you, because that took a lot of effort to get there. It is meaningful for the person. Look at the nonverbal messages. And we communicate in a lot of different ways. And so if we can't have a conversation anymore, how about reading to me? How about let's listen to some music together, music that I've always enjoyed. There's something really special about being present with the person. And there's something really special about doing things that they enjoyed with the person. So look for those opportunities. And when you're leaving the room, always say goodbye. Even if you feel that the person didn't really notice that you were there or not, always say goodbye. So now I want to talk about working with people with intellectual and developmental disabilities and dementia. Within services, working with providers for people with intellectual and developmental disabilities, we've had a particular philosophy of care. We've worked very hard to build that philosophy of care. We want people to be in the community. We want to help them with controlling their own lives. We've worked with people to build a network of relationships. We've hoped that they will hold a job. And in some ways, we make a promise to people with intellectual and developmental disabilities and to their families that the person will have more independence this year than they did last year, and that will continue to build. So when I think about our philosophy of care, I still think that when a person has dementia, we should still be thinking about, okay, so how are we going to ensure that someone can still be in the community, that they have some control in their lives, that those relationships that are important to them are still part of their lives? Perhaps they can't be in a job in the same way, but can they have the interactions that they had in the job or in a day program? And if more independence is not possible, what can we do that the independence they have is maintained for as long as possible? So we really have to question ourselves about, in our approach to people with dementia, are the same ideas and principles of value in what we do. And I think this also applies when simply from aging, that aging is not dementia, but in some ways we may behave towards people in the same way. And we need to be continuing to emphasize all of those principles. So then I look at this issue of quality of life, which also has really influenced the way in which we provide services and what we think our services are for. And when I look at the challenges for people with intellectual and developmental disabilities and Alzheimer's disease, and I think about their quality of life, I think about things like an absence of pain. Well, we can't help people to not have pain if we're not identifying pain and we're not treating pain. We need to be looking at how we maintain people's health, both physical health and mental health. We're not going to give up because someone has dementia. We want to be helping people to maintain skills that they've had. We want to support them when those skills start to change. We want to, as I talked about the disease, and as you saw in the video, you'll see that there are some breakdowns in people's ability to control their own behaviors. And so we want to set up an environment where there's probably a minimal number of problem behaviors, and we want to be sure that we know how to respond in supportive ways. We want to keep being sure that people are able to participate in the community and in things they enjoy, in particular, their contacts with families and friends. But we also want to be looking at sort of how we can make our programming more dementia focused. We want to look at the environments where people live and where they're going to, for example, day programs, to ensure that those environments are supportive. And we want to recognize that all of this is very demanding on caregivers, family caregivers, and on staff caregivers. And we need to be thinking of ways about how we can help caregivers with the burdens that they're experiencing. So I mentioned before, as we all get older, it's an unfortunate thing that sort of part of that is that we tend to develop additional health conditions as we get older. And that's true for all of us. And those health conditions increase as we age. They also increase as dementia progresses. So for people with an intellectual or developmental disability, when something like heart disease also appears, when something like, for example, a seizure disorder also develops, it's a real challenge to people's independence. And in some ways, additional health concerns represent a bigger challenge for people with intellectual and developmental disabilities than it does for everyone else, because small declines in my level of independence can have big consequences. I may have always had difficulty walking. If I end up having greater difficulty walking, the pathway to being in a wheelchair it is often shorter than it might be for someone else. And so there's a real need for active medical management of all these other health conditions that may be present or may be developing, so that we make sure that we don't end up moving too quickly to restrict people's independence. We also need to be looking at the impact of life events and changes. As we get older, there's a greater likelihood that there may be the death of a parent, a close relative, a significant other. Also that those individuals are also getting older. They're also likely to experience illness, and hospitalizations and even sort of placement in nursing homes become part of the life experience of those individuals who are very close to the person with an intellectual or developmental disability. How well do we explain those changes that are happening for those individuals? That for a person with an intellectual and developmental disability, it may be only that what they know is that somebody who used to come and visit me doesn't come and visit anymore. And so there's the impact of those kinds of losses, the impact of being placed or moved out of the home. For example, if a parent who's always provided care is placed in a nursing home, I, as the adult son or daughter who was being cared for, may have to move somewhere else. I also may be moving further away from those caregivers, or perhaps they're moving further away from me. And also then think about what happens when there are changes where I'm living, where perhaps other people have moved out of the home, where staff have changed. Those are all things that I experience as major changes in my life, as losses, as separations. And then the whole issue of retirement and aging out of programs, and feeling the separation from what I viewed as a productive part of my life, and also a lot of relationships that are there. So hopefully, as you hear me talk about this, you're thinking, well, that happens for me too. That's what retirement might be like. That's what's happening to other people in my life as well. But we have greater both control in those situations usually. We have a greater understanding of the meaning of those situations. And also when they occur, we're more likely to more immediately express our concerns about those losses and separations. One of the things that happens, not for everyone, but for a lot of people with intellectual and developmental disabilities, is that they may not express, they may not recognize those losses, or may not recognize the meaning of those losses for much longer than would be true for most of us. So at the point where someone's behavior seems to change, the person becomes more withdrawn, it might be 6 months after a major event has occurred, that we all decided, no, the person coped with that really well. But 6 months later, that's when we see the impact. But will we remember this major event that happened? Will we understand that that major event is influencing some of the behaviors that we see? Or will we say, well, he's getting older. She's showing signs of dementia. This is probably just part of the dementia, these behaviors. And what's important about that is that we can do something about things that are not due to dementia. And so we really should be looking for those things. So we should be looking them, as I said earlier, in terms of physical health changes, and we should be looking at them in terms of the losses and separations that the person's experiencing. And what can we do to better support the person because of those things, so that then perhaps some of the symptoms that we're seeing will go away. So the other thing that I think about with this, and I think all of you should be thinking about, is that if you think about dementia as having an early, a moderate, or a middle, and a late stage, that the services that you need to provide someone, first of all, before dementia symptoms occurred, then think about what they're going to need in the early stage, what they're going to need in the middle stage, what they're going to need in that late stage. We need to be thinking about what's the mix of services that people need, certainly, but it's not going to be a fixed mix. It's going to change over time. And are we setting up plans that will be flexible enough for that? We need to be thinking about what's the best place for services that we're providing. Is day programming always best delivered, for example, in a center away from where someone lives? Or should we be looking at bringing some of those services to where the person lives? Should they be there 5 days a week? Or should we be looking at a smaller number of days because of the person's needs, not our needs, but the person's needs? So I think that we need to look at the services that we provide, and we need to be clear about what is it we're trying to achieve with those services. And then we should also be looking at how do we make our services more dementia specific. So then I want to also hone in on person-centered planning. Person-centered planning is something that has very much influenced services for people with intellectual and developmental disabilities. And because we've done this for a long time, because we've done a lot of meetings, because we've gathered a lot of information, we've written a lot of reports, it teaches us an awful lot about the people that we care for. We know their needs, their wishes, their desires. We know the things that they enjoy. And when people have dementia, they're often no longer able to adequately express those things, but we already know them. And so we should be thinking about how do we utilize both the techniques that we've used around person-centered planning, but the information that we've gathered to help people be more successful when dementia symptoms occur. So now I'm just going to talk about personal care and so some of the things to think about. What changes when we're providing personal care when people have dementia? But one thing that definitely changes is that there are some people who were able to do some things very independently for themselves, and they're now going to need assistance. And they're not necessarily going to appreciate receiving that assistance. They're still going to want to try to do some of these things for themselves. So I think about these key principles when it comes to personal hygiene and grooming, that attending to personal care offers an excellent medium for communication and for social activity, that you are spending time with that individual and it's exclusive time. You are thinking about the things that are important to them. You're communicating with them about those things, but it's also about recognizing that clothing, how I'm dressed, how I'm groomed are, part of my sense of well-being. It's a part of my sense of my personal identity. A very good friend who does a lot of research in the area of Alzheimer's disease and around care for people in the later stages of the disease. And one of the things that she often talks about is that she hopes that if she were in the later stages of dementia and people came to visit her and she couldn't really communicate for herself anymore, that the first thing we would look at is to see whether or not she had her makeup on that morning. And if not, that we insist that whoever's taking care of her do that, or that we help her to get her makeup on, because she never walked out of the house without her makeup. And she was like, and that's part of me. And I don't think that people are paying attention to who I am if they don't think that's important too. And so think about those things in terms of, what are the favorite clothes that someone likes to wear? How do they like their hair to be taken care of? Let's give people the opportunities to still be themselves despite their dementia. To know that everyone is different. And if you're struggling with, well, I'm not really sure what the person would want, well, then we need to go back and think about what were their preferences, what is their taste. Let's talk to other people. Let's look at the information we've gathered over the years through person-centered planning, and let's really help them to be the person that they've always wanted to be. There will come a point where they can't indicate their personal care preferences. And it doesn't mean that these things are not important. We really have to give careful attention to these important care issues. We need to adjust bathing to the person's personal preferences, particularly if a person has been moved because of their dementia. That sort of, we really need to explore whether or not they like to take a bath, they like to shower. We need to be careful about avoiding forcing people to bathe. We can always try again later. And also, even though sort of this may be in a routine that worked really well in the past, we may need to adapt it to really ensure safety and comfort. Perhaps look at things like non-slip mats, is an assisted bathtub or grab rails. We often have grab rails, but are they the right grab rails? Are they in the right spots as people become more impaired because of dementia? Bathing will take longer. And so we need to make sure the area is warm, clean, and welcoming. We need to not rush this activity. A person will get upset, and rightly so. So perhaps we need to change the times. So if a lot of people are taking their shower in the morning and there's, other people need to get into the bathroom, well, maybe it's not the right time. Maybe we should take it to another time where it's less rushed. Or perhaps those other people might change their time so that the person with dementia can have more time. As a person helping the individual, you need to have everything ready before you start. And that sounds simple, but really sort of think that through, make sure everything's there, including the things that I'm not sure if I'm going to need. Err on the side of caution, making sure that you have everything that you need. because you really don't want to be leaving the person standing on their own in the bathroom while you go to get something. Make sure the water is the correct temperature and check that the person's comfortable. Understand that when people have dementia, they become less sensitive to extremes of hot and cold. They also may become more sensitive to hot and cold. So simply because it worked before, it doesn't necessarily work now. And so check that the person really is comfortable. Again, bathing is going to take longer. So, pay even more attention and have more sensitivity to the person's privacy. And this is not a time for other people to be coming in and out of the bathroom, checking in with you or whatever. Like, let's really try to respect the dignity of the person and their right to privacy. As the dementia progresses, it may be that two people are needed to bathe or shower the person. And there's a real danger in that particularly when the person's not able to communicate much anymore, that the two staff or the two family members who are providing care, they end up having their own conversations. Try to include the person in any conversation. It shouldn't just be a social occasion between those providing care. Acknowledge the presence of the person. In some situations, when the person is having great difficulty in managing their own bodies, that you may be utilizing hoists, for example, to get the person in and out of a bathing area. Again, respect privacy, explain what you're doing, do it slowly and gently, taking them through each step. So really sort of take a look at the grab bars. Do they really work? Walk-in showers always work better. Adaptive bathtubs always look better. Why do I have to stand when I'm being bathed? Maybe let's put a chair in there. And then, in so many bathrooms, you step into a shower, you turn on the faucets, and the water comes down on top of your head. And you're used to that and you're ready for that. When a person has dementia, they're not used to that anymore. They don't remember that that's what's going to happen. It can be actually a pretty frightening experience. So what I do see people doing a lot is, installing handheld and adjustable height showers and shower hoses and nozzles, so that it can be a little less intimidating, that you have more of an ability to explain to the person and show the person what's about to happen. And that actually brings up the larger issue of managing environments, whether it's the environment where people live or the environment where they're going for day programming, for example. When we have dementia, it's a very challenging experience, because we have less and less ability to process all the things that are going on around us. And being sensitive to what's happening for a person with dementia, I think one of the things that you come to realize is that there are an awful lot of things that we just sort of phase out, that we don't pay attention to day that are going on around us. But when you have a dementia, well, first of all, there's the issue of that if I've been moved, this is not my home, these are not my things. It's disorienting. But then I think about things like noise, light and shadows, being able to find my way around, being bothered by other people or by too much activity, feeling hot, feeling cold, and just a very basic issue of, am I comfortable? When I do trainings in person, I always ask the group in the room at this point, so tell me about the room. Is it too hot or is it too cold? And I ask for a show of hands. And I always get three groups. I always get the people who say it's too hot. I get the people who say it's too cold. And I get the people who say, no, this is just right. Well, if we're okay with that reality for ourselves, we need to recognize that simply because I think it's okay doesn't mean to say that the person with dementia thinks it's okay. And so we always need to be testing these things from the perspective of the person we're providing care for. So I think about ways in which we can simplify the environment, about helping people to get oriented. And I think about the impact of furniture, noise, illumination, color, and flooring. So we have worked very hard to ensure that people are living in homes that look like every other home, that are comfortable, they're home-like. And unfortunately, comfortable and home-like usually means they're a little bit cluttered. And there's things like lamps on tables that are not very secure. And so when people have dementia, we often need to just do that scan and sort of think about, well, do these pieces of furniture, should they still be here? Are they sturdy enough? And are there things that we should just take out, like lamps, like throw rugs on the floor that are just trip hazards for a person with dementia? But it gets actually a little more fundamental than that. We also need to be looking at, are surfaces of tables, are they smooth? Are we using patterned table mats, for example? Patterns are increasingly difficult for people with dementia to make sense of. Patterns many times don't make sense. And then if you don't know that they don't make sense, well, then they really don't make sense. If you understand what I mean, it can be confusing. Think about the furniture that you have, that, it's better if edges would be rounded rather than sharp, because as my dementia progresses, I have more difficulty negotiating around furniture. Is the seating appropriate anymore? That sort of, we often have chairs that match and things like that, but is that, those the chairs that I really will benefit from? One of the things that I've seen happen is that people have often added rocking chairs, for example, because they can actually be quite calming for some people with dementia. I've seen a lot of focus on family style dining. Perhaps the people in the house and including the staff all sitting down together. I've always been incredibly supportive of that. But for people with dementia, perhaps smaller groups will work better. And then in day programming, I'm very struck by the number of long hallways there are. And that when I have dementia and I'm walking down that long hallway, I start to wonder, will it ever end? And so can there be seating that sort of, where I can just take a break? So noise is an interesting issue. So when you think about when you go in to meet with someone where they're living, or perhaps in a day program, and you've got, perhaps the TV is on, perhaps it's a summer's day and we've got the air conditioning on, perhaps there are other people talking, perhaps there's overhead music playing, that I think that we can all understand that though all of those noises can be really distracting. But sometimes it's about the very location itself. That, recognizing that, when we have opposing walls, floors, and ceilings, essentially what we are creating is parallel surfaces. And when those surfaces are hard and utilize smooth materials, then they reflect rather than absorb sound. And so they amplify sound. So again, we often get used to that. We don't pay a lot of attention to it. When I have dementia, I pay more attention to those things. So looking at things like carpeting, acoustic tile, wall hangings, curtains, other sound absorbing materials become really important as a way of trying to reduce the overall sound in a location. So I think again about dining rooms, kitchens, areas where we're eating tend to be noisier. So what can we do to try to reduce the noise in there? I think there's an awful lot of background noise in terms of TVs and radios. And in more recent times, many of us are sitting with our earbuds in, and we're not listening to as much of that. But I don't see that as much for people with intellectual and developmental disabilities. I still walk into rooms where there's a large TV, everybody's watching that TV, or it's just on in the background. There's music on in the background. And then There's also a lot of social activity going on among the people in the rooms, but also among the staff or among other family members. All of that represents noise that can be difficult for the person with dementia. So, how do we sort of take a look at that, pay attention to that, try to reduce some of that noise? Then I think about lighting. So I'm sitting in the living room. It's a summer's day. It's quite a sunny summer's day. The window's open. There's a little bit of a breeze. And at another time in my life, I would say that was a really enjoyable moment. I like feeling the sun. I like feeling the breeze. I like the idea that it's summer. But when I have dementia, that becomes more complicated. As you see in this picture here, light creates shadows and casts shadows on the floor. So in the example that I just gave you, if this window was open, or one of the panes in this window was open, and there was a little breeze blowing, well, then the curtain would be moving, and the shadow created on the floor would be moving as well. Now, I know if I saw that, okay, well, the sun's shining, it's casting a shadow, I have the window open, it is breezy outside, that's what's creating the shadow. For a person with dementia, all they know is something's moving on the floor, and I don't understand what the shape is, and I'm afraid. So shadows are a problem. They create visual illusions for the person with dementia. So we need to be looking at how we use curtains or tinted glass to try to eliminate shadows. We, probably need to utilize more indirect lighting, dimmer switches, and also that people are likely to get up during the night and things like that, that we should have night lights. Sometimes we take great pride that we have buffed or waxed a tile floor to a real shine. That shine is difficult for a person with dementia to manage. Sometimes, because of different rooms in the house, we have really bright lights in the kitchen. We have dimmer lights in a living area or in a bedroom. Sudden changes in light levels are confusing for a person with dementia. And then there's an interesting issue with mirrors. Does not happen for everyone, but for some people, it can cause confusion. I look in that mirror and I don't recognize my own image, but this person is watching me. And if I can't make sense of that, that can actually be pretty scary. So we need to assess that by individual, but sort of to really think about how lighting and mirrors, can create confusion for people. I think as well about colors when I have dementia, that we tend to manage colors in the red to yellow range better than colors that are in the blues to greens. And solid colors and simple patterns are better than complicated or highly unusual designs. But I also think about the color can be really helpful in helping me to negotiate my way around my own home. If I'm walking up the stairs and the wall is white and the stair and the stair rail is white, I don't know where the rail is to be able to hold on and to feel secure. But if it was a different color, I'd see that and I'd feel safer. When I walk into the room and I want to turn on the lights, and I reach over to the light switch, and it's just the reality that the switch and the panel behind it are all the same color. Well, what if they were a different color? Then I'd be able to see the switch and I'd be able to turn it on and off for myself. So sort of finding ways to create those visual contrasts mean that I'm able to do more things independently and I'm able to feel safer. So it just so happens that pale colors blend easily with other pale colors. So we want to choose colors that are attractive and home-like, but also which offer contrast. So I talked about the handrail example and the light switch example. But one of the other ones that I've seen, I was working with a day program and they were looking to discharge someone with dementia because they said that he was having a lot of toileting accidents and they really didn't have the staffing level to be able to support that. And I walked into the bathroom and I looked, and the toilet seat was the same color as the toilet. They were both white. And I realized that probably for the person with dementia, and he was at a moderate stage at that point, he was looking at that and he was looking and he didn't think there was a toilet seat on the toilet, and he didn't want to sit on the toilet if there was no toilet seat. So I asked them to try, a $3 toilet seat that was a different color, and his toileting accidents went away because he could see the contrast. And it's also, the picture here, shows placing a dark placemat under a light dinner plate. When I talk about meal times, we want to keep the things as simple as possible. Place down in front of me what it is that I'm going to eat. Put it on a plate. Give me the utensil that I need to eat it. I don't need a whole series of other utensils or condiments and things like that will only confuse me. But help me in this particular case to be able to find the spoon and to be able to place it into the bowl so I can eat for myself. And the darker color placemat helps give me definition, helps me to find my way around on the table and continue to eat independently myself. So I think that we are often really concerned about particular areas in the home or perhaps in a day site where the individual may be doing things or may be at risk for injury because of their advancing dementia. And this slide, I give sort of examples of things that people have talked to me about as to why they sort of want to restrict a person from the kitchen. But what I always think about is that, are there ways in which I can still let the person be in there, particularly if it's important to them to be there? And so there's a series of examples here, excuse me, of relatively discrete ways of making it harder for the person to get into areas that we don't really want them to be in, or to do things that we want to try to control, but still mean that the person can be in the kitchen. So think about that in terms of the kitchen, in terms of bathrooms. What are things that we can do? I think about certainly, again, I think about this both in terms of aging as well as in terms of dementia, that we want to be increasing access by, recognizing that people may be in wheelchairs rather than walking as they have in the past. I think about appliances being off the floor. The example here is of a dishwasher that's raised up. When you reach down to get something out of the dishwasher, it can be disorienting. You can lose your balance. You can even forget why you're down there. Moved a little higher, that's less likely to happen. Perhaps having shelves that slide out. There are always going to be some things that you want to be able to control, cleaning supplies, things like that. But place them in a cabinet and make the locks on them very discreet. If you don't want people going into the cabinets, well, how about having the dishes that they will need sitting out on the countertop so that there is no need to do that? If I see it, I will use it. If everything's behind a cupboard door and I no longer remember what's behind each door, I'm going to open each door and I'm going to take things out looking for the thing that I really want. Make it easier for me to find the things that I really want. I think a lot about sort of how we can take that same approach to improving access throughout the home. Let's, if the stairway permits it, let's put a double rail that I can grab hold with either hand. At the top of the step, let's have a hand grip, or at a stairway. Put something down that helps me to see where a step ends. Too often, for example, with carpeted stairs, you can, and particularly if it's a patterned carpet, you actually don't know anymore where the step ends, and you're more likely to fall. We often have, one step down, try to eliminate those steps. Sometimes we have raised door sills, remove those and put a flat plate. Find ways to remove the trip hazards, find ways for people to have something to hold on to so that they feel safe. Flooring's a really interesting issue. So if you look at this particular picture, it's a very attractive looking floor. It's a very scary floor for people with dementia. First of all, the pattern with all the little black circles, those look like holes in the ground. And you're expecting me to walk across those. One of the things that's interesting about this, if you look towards the red armchair, you'll see that it changes from the tile to the carpet. Do you notice that actually there's a step down there from the tiled floor to the carpeted floor? There actually is a step down, but for a person with dementia, they may not see it. Again, sort of think about high gloss finishes, because that creates reflection and it creates illusions for the person, and avoiding patterns such as the pattern here. I think that we are always very concerned about the potential that someone might leave, and the potential that they might leave is highest probably during the moderate stage or the middle stage of dementia. So we want to leave doors unlocked. There's good reasons why we want to do that. So what we've done a lot of work on is setting up alarm systems that alert staff, not that prevent people from leaving. And that those alert systems be, the examples that are here, that there's a contact point on the door. If the door is open, the alarm goes to something that's carried on the belt clip by staff, and it vibrates. It doesn't make a loud alarm because we don't want to upset the person, because they won't understand what the noises are. But as staff have said to me, it gives them a fighting chance to catch up to the person before they really leave the premises. So sort of looking at things that can help in that way. Sometimes there are areas that we just don't want people going into, and I think closets where we're storing cleaning supplies. Let's pick a closet where all the cleaning supplies are in, so that we don't have to then limit the person's ability to be in other places. But let's use something like this, which is just a contact poster that can go over a door and mask the door. I was in a nursing home a number of years ago. I was on the 4th floor, and they actually had the bookcase posters. They had put it all along the bank of elevators. And I said to them, I said, so how's that working? Because this was a group of people who were not able to leave the floor independently. And I said, how's that working? And they said, it works pretty great. It's that the only thing is that families and inspectors always seem to be coming up and asking us, where's the elevator? Because it works a little too well, that people don't recognize that the elevator's there. I think, absolutely never put something like this on the door that people need to be able to recognize and utilize. But yes, that locked closet, because a locked closet calls my name. I'm going to want to try to get in there. But if you put a masking poster like this on it, I don't even know it's there. And so we avoid a lot of problems. I also think about that if we try to restrict, if we feel we need to restrict people from certain areas in the home, there needs to be somewhere else to go to. And so I also think about creating pleasant places to be. So this is an example in a group home where they took a porch that they were not using very much, improved it, made it like a very pleasant place to go, but also a very safe place to go. So I'm going to ask you to think about something, both for yourself and for the people that you work with. What are 4 things based on what we've been talking about here that you're going to do together to improve care for people with intellectual and developmental disabilities and dementia. So think about, are there changes you want to make in the home, in the day program? Are there ways in which you're going to try to communicate differently? Are there ways in which you're going to change some of your care practices? Think about what other information you need. And think about what support you need from other staff to do that. So 4 things you're going to do together. What's the other information that you need? And what support do you need from others? So I want to talk specifically about day programming for a few moments. And I realize that in a lot of states, and certainly in Ohio, there are changes happening to your day programming. There's a lot of strategic planning going on in that regard. But when we created day programs, we were really focused upon helping people to prepare for work, to be productive. We wanted activities that were age appropriate. And we were focused very much on young and middle adults. They were not really designed when we first created them, thinking about that there was going to be an aging population. And the result of that is that there has been a tendency for day programs when dementia occurs to send someone home rather than try to find ways to accommodate their dementia. And that's challenging. When people aren't able to go to a program during the day, it increases demands, whether it's on providers' residential programs or it's on families. But it also decreases the quality of life for the person with dementia or Alzheimer's dementia, as I say here. It's really helpful to me in dementia to be going to places that I'm familiar with, to see people that I know, to do things that I've always done. So we've done a lot of work, and we've been encouraging people to think about how they might change their day programs to better support people with dementia. That rather than large group, it's more likely to be small group and one-on-one. That they too should be looking at the issues of lighting, of noise abatement, flooring, and giving people clues. One thing that when I work with day programs, they talk to me about is that one of the challenges that they have is that the person with dementia always wants to be at the reception desk. And I point out to them, because it's usually the case, that all the signage says go to the reception desk, and that and there's a lot of activity at the reception desk. But if you don't want people standing at the reception desk, there has to be activity somewhere else that's even more attractive. That they need to be looking at their bathroom areas so that they are sufficiently accessible to be able to deal with toileting accidents. That there need to be spaces to wander safely inside and out, and that there need to be places to sit. This is actually, the picture here is an example of an area that one provider created, and it has raised beds, and the individuals with intellectual and developmental disabilities and dementia actually participate in maintaining the raised flower beds. And then that we should be looking for activities that people will really enjoy. Again, sort of the gardens, maybe there is a kitchen, maybe there's a memory room, maybe there's pottery activities, maybe there's something like a beauty salon that we are not teaching people how to do their hair or whatever, but that it's just some place that they can go to and enjoy having someone take care of them in that way. That it be a safe place, but not at the expense of supporting continued independence. That we still want people to have the opportunity to do things that they enjoy. So we want that the programming will be multi-sensory in approach. As a part of dementia, our senses become dulled. So our enjoyment of experiences is often about appealing to multiple senses. But that it should be stimulating, but it also should be calming. that we should be supporting existing skills and memories rather than trying to teach new things, that we tailor it to people's likes, dislikes, and previous experiences. And that, yes, once again, that we sort of think about reminiscence, about the memories that I still have, trips in the community, walks, simple exercise, massage, something that's called snoozling, which is about sort of sensory stimulation, horticulture, pottery, art, music, aromatherapy. Wouldn't it be nice for all of us in our older age if we were able to go to a place where we had the choices of those kinds of things, and that we were being supported by people who were trained in dementia issues and who thought that our quality of life was really important. So it requires a commitment to maintain day programs despite dementia needs. I don't want to pretend that it's easy to make these kinds of changes, but I think that there's a huge payoff in terms of the quality of life of people with dementia if we're able to achieve it. So this is just a little bit more information on snoozling, because when I bring it up, people often ask me for more information. So it's really, designed to appeal and stimulate the primary senses without the need for any kind of intellectual activity in an atmosphere of trust and relaxation. It's failure-free. It maximizes the senses. And, there are, in terms of the programming that we then can potentially provide, there are a number of evidence-based approaches that are proven to really be helpful for people with dementia. And I think horticulture therapy is a great example. We have tended to approach that as a therapy with intervention goals, someone qualified to deliver the intervention, and a particular problem that we're seeking to address. And there are issues that we're seeking to address, but I think that it's much more about the experience. The other piece is that I think that horticulture therapy or horticulture activities really give us an opportunity to engage with the community. I've seen a number of providers where they've gotten participation from local garden clubs, nurseries, and florists who often actually donate a lot of the materials. But you can also expand the activity to include trips to public and private parks, to gardens, to greenhouses. And often it's built upon activities which the person's familiar. What makes it more organized and evidence-based is that it's based around a series of activities. And so we need to be clear about the activities. We need to present them in a clear, organized fashion. You present it once in a demonstration, and then you repeat it as needed to teach each member of the group that it is not simply an activity where the person with dementia is watching, that they actually get to participate. So again, think about this in a multisensory way, that it's not just that I see what's going on, I put my fingers into the soil, I feel the plants, I get to smell the plants. Multiple senses are being appealed to. Music therapy is also an important strategy, and again, one in which in intellectual and developmental disability services, we have utilized a lot over the years. So there's, again, a sort of a built-up series of experiences for people with intellectual and developmental disabilities. It's a form of sensory stimulation. It provokes responses because of familiarity, because of predictability, and also, depending on the music, oftentimes a feeling of security for the person. And because often we are utilizing music or songs or instruments that the person's familiar with, it contributes to reminiscence and satisfaction with life. There are positive changes in mood and emotional states. Within this experience, there can be a greater sense of control, greater awareness, stress reduction, a reduction in pain and discomfort has been reported as well. And it provides a structure that, is really around movement, around vocal fluency, and opportunities to interact socially with others. So it can be around the use of instruments, singing, but again, sort of think about this in terms of community participation, that we can go out to concerts, we can participate in group music activities, we can listen to music. And I've seen a lot of work done in terms of developing, whether it is a CD, if that's what the person can manage, or if they have a smartphone or their own personal technology, that we can build a little library for people around their music interests. But again, it's about connecting with previous skills and interests. It's about choosing music, and it's about the means of delivery that the person enjoys. Again, we're often today much more focused upon, well, let's build this up, let's give somebody some earbuds and they can just listen to their own music, but that may not be what the person can tolerate, what they're interested in at this point. So we may have to experiment a little bit with sort of what's the best way to deliver. And sort of sometimes it is about more group music activities that people can participate in. So these are just some other interventions. Pet therapy, bringing in of animals that are therapeutic is really helpful. I mentioned rocking chairs before. There was a study done looking at where people were given the opportunity to spend 30 minutes a day sitting in a rocking chair, and they saw reductions in stress and increases in satisfaction. Sometimes there are behaviors that really do challenge us, and so I'm going to talk a little bit about challenging behaviors. But behavior modification does have its role, but it's more difficult with a person with dementia. And then we're seeing a lot of use of complementary medicine and therapy approaches. The Electronic Dementia Guide for Excellence is something that was developed in New York for nursing home residents with moderate to severe dementia. And I've utilized many of the interventions that are on this particular website because often they work really well for people with intellectual and developmental disabilities and dementia as well. But let's talk about problem behaviors, challenging behaviors, behaviors that challenge. So every person who has dementia does not have challenging behaviors, but nevertheless, there are some behaviors that we do see in some people with dementia. And I think it's unfair to pretend that they don't happen. And so this particular slide here sort of gives you a sense of that, there's no one behavior that's associated. You will see apathy and depression. You'll also see some aggression. You may see psychomotor agitation. And in a small number of cases, you may see things like hallucinations and delusions. You also see a lot of misidentifications. And much of this relates to the changes that are happening in the brain for individuals. Much of these behaviors are likely to occur more in that moderate stage because that's where some of these critical areas are breaking down. In the severe or late stage of dementia, precisely because there's been more breakdown, that some of these things don't happen anymore. And so sometimes family caregivers in particular talk to me about missing some of these behaviors because they know that it's a sign that the dementia really has advanced. So these kinds of behavior and personality changes and difficulties around managing them are often stressful for caregivers. And caregivers talk to me about them being more stressful than the cognitive changes. So, this agitation, this particularly agitation is seen because some of it's dementia related, and some of it's dementia specific. Again, I go back to what I said before about the need for active medical management, that there can be things like pain, constipation, sensory impairments, infections, side effects to medications, that they're not part of the dementia, but they're occurring at the same time, and that the person is no longer able to explain what's going on. Or perhaps we're not paying as much attention to some of these things because we think that what we're seeing is all about the dementia. Like I'm someone who's worn glasses all my life, and I think about that. If I'm at the point where I have dementia, that probably people will be concerned I'm going to break my glasses, whether purposefully or accidentally, and might think it's a good thing that they're taking my glasses from me and putting them aside and giving them to me when I really need them. What I know is that without my glasses, I can see very little. If I'm sitting in a room and there's a lot of other people, I can see colors, I can see blobs, I hear voices. Now I know that all I need to do is put my glasses on and I can make sense of all of that. For a person with dementia, they don't know that. All they know is there's blobs, there's colors, they're moving around, they're making noises. It's scary. And so paying attention to things like glasses, to hearing aids, are really important. But I think too that it's really important to be looking for, are there things like pain that's not being treated? Are there things just as basic as the person being constipated? That's the real explanation for the behavior. The other piece that we think about is that there can be a misfit between the person and their physical and social environment. And that's where I think about some of the environmental changes that I've been talking to you about, is that the place is too noisy for me. There's shadows and I'm afraid. Those are things that will contribute to my behaviors. So, all of that, I'd argue to you that those are all things that it's for us to address, not for the person with dementia. And these are all things that we can do something about. It requires us to pay more attention to some of these things, to make some changes, to be very active in the management, for example, of physical health problems, to try to reduce the occurrence of agitation. We need to recognize that a person with dementia gets very disoriented to time and place. As the disease progresses, they experience what we call disinhibition. There are things that we don't do because we know that they're not appropriate to do in a particular time at a particular place. When I have dementia, I don't know that anymore. And so that everybody else feels that what I'm doing is inappropriate, but the person with dementia doesn't necessarily see that. There's a lot of failure to recognize, but also there may be some underlying and previously existing conditions, such as a depression, that are still there and may actually be aggravated by the person having dementia. So this is definitely a situation where the multidisciplinary team should be very involved in sort of monitoring. This is where, going back into the records, you may see that, okay, well, this person was depressed in the past. And it's also an area where, we might look at, well, what worked before? So one of the problem behaviors that people talk about a lot in dementia is what we call wandering. First of all, I always think about, is this really all bad? The person's getting exercise, there's some stimulation that's occurring from that, should I be trying to stop the person from pacing or stop the person from wandering? Or should I be trying to find a way to accommodate these behaviors? And I think with any situation with challenging behaviors, the first thing is, well, is it really a problem? Is this something that we can tolerate? Is this something that we can accommodate? Is this something that the person actually may be getting a benefit from? And therefore we should be really trying to facilitate. So I think the goal is a safe level of wandering without putting the person at risk of injury. So no, someone leaving the house and walking out into a busy street, that's a problem. That's a real problem. But someone going out into the backyard and pacing, is that a problem, or is that something that we can, make sure it's a cold day, make sure he has his coat on. It's a summer day, make sure she's got sunscreen on. Trying to find ways to accommodate. Also to think about, what does the wandering behavior mean? So colleague has an approach to this that I find very useful. She talks about that there's what's called exit-seeking wandering. Usually occurs at the mid-stage of dementia, and it's highly motivated and it's very goal-directed. The person wants to leave. But what she argues is that there's two different kinds. There's the group that she calls the Elopers and another group she calls the runaways. Elopers are people who think that they're just visiting. They need to leave. They'll actually tell you that they're going to leave. Somebody needs me. I gotta, I go to work every day, and perhaps they did go to work every day. I need to leave. I'm telling you, I'm going to work. The runaway is somebody who's really worried. They feel prevented by you from leaving, and they'll sneak out or they'll bolt. And then there's this last group, the self-stimulatory and restless pacers. They don't really have a desire to leave. They're pacing. It just happens that they accidentally leave. So then I think you need to step back and think about, so what happens day to day in this person's life that may make it more possible for them to leave? And there are two opportunities for leaving. If I'm determined to leave, there are two opportunities for me to leave. After each meal, and particularly if it's an out-of-home placement or it's a day program, at shift change. After the meal, we're always going to do something new. Okay, I'm going to do something new. I'm going to leave the building. So you better have something new for me to do. Otherwise, I'm leaving the building. But if you give me something better to do, I won't. And then when other people are putting their coats on and leaving, well, that's a real prompt for me to leave. So we really have to be thinking about sort of purposeful activities and distracting kinds of activities so that those situations aren't a prompt. But I think that a lot of what we're doing is really trying to understand what the person is communicating to us. Behavior is an attempt to communicate. Often it means there's a need that's not being met. Let's try to find the need. Sometimes it's about a memory. So let's talk to the person about that memory. But don't place yourself in jeopardy in the midst of this. Always try to find safety for yourself, for the other people in the home or in the programming area. But fall back on what we've really been well trained to do, to analyze the situation. Why does this behavior happen? What's the who? What's the what? What's the where? What's the when? How often? Often we can solve this for ourselves, but this may be where we might reach out to the multidisciplinary team to provide some help as well, to try to understand what's going on for this person. So most of us were trained in what we call the ABC approach to problem behaviors. The A is the antecedent, what happens before the behavior. B is the behavior itself, and C is the consequence. Classic behavior modification approaches usually try to influence the consequence. We don't want a behavior to be reinforced. And sometimes we look at the antecedents. We look at sort of, well, what could we do that would have prevented the behavior from happening? When someone has dementia, I think there's very few situations where we should be looking at the consequences. I think we should always be looking at the antecedents. What could we have done that the behavior doesn't happen? What can we learn from a problem that we had, that problem doesn't need to happen again? That a successful day is measured in terms of the number of problems that we avoided rather than in the number of problems we solved. And so becoming a good detective of sort of what causes some of these things to happen, that's how we're going to really support a person with dementia. So I get a lot of questions about the use of medications to manage the symptoms of dementia. And are they being used among people with intellectual and developmental disabilities? And should they be used among people with intellectual and developmental disabilities? So I'll just say a couple of things. And I'll precede that by saying, I'm not a physician, I don't prescribe. And so anything that I say here is not prescribing advice. What I can say is, as a researcher who looks at these things, that most of the large-scale studies on the medications that are being used in the general population did not include people with intellectual and developmental disabilities in their samples. And so what's being reported for the general population doesn't necessarily apply for people with intellectual and developmental disabilities. And this is actually true of a lot of medications. There have been some small-scale studies that have focused in on people with intellectual and developmental disabilities. And at best, I can say that the research evidence is of limited effects. I still know that there's a lot of prescribing in different parts of the country for people with intellectual and developmental disabilities. But all I'm saying is that the small number of studies that are available, and they are all based on very small samples, haven't shown a tremendous effect for those medications for people with intellectual and developmental disabilities. I think on a case-by-case basis, any use of those medications should be monitored by the prescribing physician. And if the physician feels that they are getting the effect that they're looking for, that's great. But I'm neither supporting or disagreeing with the use of the medications. So clearly there's not an opportunity now to ask questions, but what I would suggest that you do is that if you have questions, that you contact those who have made this video available to you. And I'm sure they'll be able to answer most of the questions. But if they're not, they should feel free to contact me and get back to you with an answer. Thank you.